Hi everyone, you're listening to Let's Psyconnect. This is LT.
And this is Ronnie.
Today we have a special guest here with us, Dr. Rosie. So we're going to be talking about Alzheimer's and aging as part of the aging series that we have on. So we hope that you have been listening to our series and then stay up to date with the topic. And without further ado, let's get started.
Yeah. So I will go ahead and just read just a short bio. We're so happy to have you on, Doctor. So I'm going to go ahead and read this, and then I'll just ask you to add a few things that you feel pertinent, okay? So Dr. Curiel is an assistant professor of clinical psychiatry and behavioral sciences. She is a licensed clinical psychologist who conducts neuropsychological evaluations of individuals with diverse neurodegenerative and neurobehavioral conditions. So without further ado, Dr. Curiel, welcome to Let's Psyconnect. How are you?
Great. I'm doing well. Thank you for asking. I'm so happy to be here.
Thank you again.
Yes, and we're so happy to have you. So I read a little bit about your background, but please provide to us and our listeners just a little bit more about yourself and your journey to where you are at right now.
Sure, absolutely. So I work for the University of Miami, right? The medical school, and specifically at a center called the Center for Cognitive Neuroscience and Aging. And this is a center that's part of the Department of Psychiatry and Behavioral Sciences. And our work that comes out of this center is really focused on developing better methods and better instruments to detect the earliest changes that occur in the older adult's brain who is at risk for Alzheimer's disease. And we really intend to do all of our work, particularly to serve the very diverse community in South Florida, which comprises, we live in a very special place where there is a very rich multicultural diversity. So African Americans and Hispanics of all different parts of the world in the Caribbean. So we really serve our population by trying to leave no one behind when it comes to our scientific work.
Which is beautiful, and we're very thankful for that, for sure. It's much needed. And so I wonder, if you could tell us in a way that it's easy, I guess, for people to grasp. So what is Alzheimer's? So we hear this word and we often think of dementia right away. But so there might be some confusion with other types of dementia, so what is Alzheimer's?
So Alzheimer's disease is one of the types of dementia. So I get that question so much. What's the difference between dementia and Alzheimer's disease? Well, Alzheimer's disease is a disease that affects the aging brain. Primarily, it affects individuals that are in their older adult years. And it's just one of the neurodegenerative conditions that can affect, the person, the way that they think, their memory, their ability to handle their life independently, to make decisions, to plan. And unfortunately, this is a very serious illness that many times leads to progression, which means it gets worse over time, and can lead to a complete loss of functional independence. It is a very difficult condition because, the person not only loses their memory and thinking abilities and the things I mentioned, but also oftentimes loses, their sense of identity within their family, their role within their family. And it's a very challenging disease for the entire family to manage.
Mm-hmm. And then what we hear about sometimes is that it can progress fast, and then in other people it's very slow. Can you tell us a little bit about that?
Absolutely. So Alzheimer's disease is technically usually considered an insidious illness. That means that it progresses very slow over time. A person doesn't just all of a sudden, overnight or over the course of a week or months, lose their abilities, right? Mm-hmm. Lose their brain-based abilities. This usually happens over the course of many years. And in the majority of cases, it's a very slow progression. But in some individuals, that have other comorbid conditions, the person might have a faster progression and lose their functional abilities faster. So for example, individuals that have a lot of cardiovascular illness, maybe they have multiple strokes, that might lead to a faster deterioration. Or individuals who have a significant head trauma. So if they already have, you know, a cognitive impairment, a neurodegenerative process going on, and they have a big head injury, that might lead to faster progression of illness, right? And of course, you know, all kinds of, you know, deficiencies that could lead to a faster progression, but usually it's a slowly progressing illness.
Because I asked that question because sometimes people say like, oh, my grandma has Alzheimer's and she doesn't know anything, like doesn't remember anything. And then you say like, oh, but my grandma or my grandpa also has Alzheimer's, but he's very still like sharp, you know, and it's still in the early stages. So there's this comparison, like, I don't understand. Is this a different type of dementia? Is it the misdiagnosis? So I think there's some confusion, you know, of like some other factors that sometimes people are not considered that can influence the development of Alzheimer's.
Absolutely. Well, you know, Alzheimer's, like any disease, can affect different people in different ways. And in some individuals, you know, their cognitive impairment, it doesn't necessarily affect their behavior, right? Maybe it just affects their memory and thinking, but in some other people, it could affect their behavior, and they might become isolated, or they might become combative and difficult to manage and angry and irritable. So it's really not just, you know, one disease with one set of symptoms. It's many different processes that are occurring in the brain that can affect different kinds of people in different ways. And many times the ways that it affects the person is governed by the brain, right? So it could affect behavior, it could affect ability to communicate, it could affect mood, right? Some people might become paranoid. Or you know, scared.
Sure. So you know, as you're talking, doctor, it seems like this is a really complex presentation, right? So I'm wondering if you could tell our listeners, how does a Alzheimer's diagnosis actually come about?
That's a great question, and this is a very important question that's very central to what we do. So first and foremost, the way that it typically happens is that a person may notice that there's a change in their ability to remember things, or sometimes the complaints are, I can't do so many things at the same time like I used to, or, you know, I really often lose my words in a conversation. So sometimes a person themselves acknowledges that there's something wrong, that there's something different, and that problem is a consistent problem, that it has become, you know, something that's occurring more frequently. Other times the person doesn't have a complaint personally, but it's their loved one that might say, you know, mom or dad, you're repeating yourself, or I'm noticing that there's a change, or there may be errors that occur in the person's life. Maybe they're making difficulties in making payments twice, or, you know, sometimes they are making careless mistakes, or before they would never, you know, do something. So it could be a characteristic change that's noticed by a loved one, and that's pretty much usually what drives someone to come into a specialty memory disorders clinic. Those are the reasons for seeking an evaluation. Unfortunately, in underrepresented minority groups, amongst, you know, a lot of the cultures in South Florida, you know, there's a different there's a different view. Sometimes people might think, oh, it's just, you know, they're getting old, leave them alone. You know, of course they're not going to remember. That's part of aging. But one thing that's really critical to communicate is that Alzheimer's disease is not a normal part of aging. Alzheimer's disease is a disease of the brain. And losing your memory or losing your ability to function independently, notwithstanding some kind of physical limitation, is not a normal part of aging. And so, you know, I think that's a really important thing to keep in mind as we increase awareness of the illness and increase the awareness of the importance of early detection of Alzheimer's disease.
You mentioned early detection, and I think Ronnie and I came across an article, and I remember from the conversations that I had with you, Dr. Curiel, in the past, that people start experiencing a change, a decline in their cognitive functioning, like related to memory, in their 30s or late 30s. And there's a little bit of noise here in the background. I don't know if you guys hear, so I apologize for that.
Yeah, I'm sorry about that. I think it's the gardeners
Okay.
working from home.
That's okay. At least now we all know.
But we can repeat certain sections if you need to, because it's, yeah.
That's okay. So what I was trying to say is that so there is this concern now, that we start losing our memory functioning in our late 30s, and so, but there's not much known, I guess, when it comes to development of Alzheimer's, and looking at how soon you actually experience this loss. Can you tell us a little bit about that? Is it something that you're familiar with? You're still studying?
Yes, and so I'm going to ask you to repeat. Did you say in your late 30s? Is that what you said?
Yeah, exactly. So we read an article that talked about that. Mm-hmm.
So there is a certain gene mutation. It's called presenilin-1. In 1 to 2% of the population of individuals that develop Alzheimer's have this mutation in their gene that predisposes them to what's called early onset Alzheimer's disease. And again, it's a very small percentage of people, but in these individuals, there is an early change in their memory and in their thinking abilities that happen, and there is an early pathological process in the brain where the brain actually starts to have the Alzheimer's disease pathology, beta amyloid, tau, phosphorylated tau, etc., occurring in the brain very early on, and the person will progressively develop symptoms into late 30s, into their 40s, and it's very devastating kind of gene mutation that leads to Alzheimer's disease in this population. There's different groups around the world that are studying individuals with presenilin-1 and with the early onset Alzheimer's disease. So there's groups dedicated to that.
Yeah. And with that, I mean, it sounds like not every single person has the gene mutation, or because people think, okay, so it's Alzheimer's, it's genetic, because my grandmother has it, my great-grandmother has it, then I'll have it. So is it something that everyone in the family will have it? It jumps generations. Do we know about it? And what are some other risk factors?
That's a wonderful question, Lisa. So, the answer is no. If genes had the complete predictive utility, then we wouldn't need all of these other biomarkers, and we wouldn't need all of these other cognitive stress tests and these kinds of things that we use in order to predict who might be at greater risk or not. So genes do not tell the entire story. What genes, outside of presenilin-1, that is such a strong gene, what genes do, including, for example, the ApoE4 gene that a lot of individuals hear about, what genes do is convey another level of risk, right? So we know, for example, that a person that has an ApoE4 allele from mom and a 4 allele from dad, so if they are a 4-4, that individual is 10 to 14 times more likely to develop Alzheimer's disease than a person who is not a 4-4 carrier. But even then, it's just because you are you have an ApoE4 gene, it doesn't tell the story in terms of predicting risk. There are so many other epigenetic risk factors that can contribute to that. So things like, like I mentioned before, cardiovascular risk, right? The occurrence of, between the heart health and the brain health, right? That cardiovascular, cerebrovascular risk, that's huge. There's other risk factors like that can convey risk. Poor sleep is being widely studied now as being a risk factor in older age, right? Hearing loss accounts for some variability of risk. Mood disorders, right, like depression, for example, that's untreated, can convey risk. Head trauma can convey risk. So there's many different risk factors that can lead to the development of, you know, a neurodegenerative process in the brain that's not necessarily genes.
Sure. Okay. So, Doctor, I want to ask just a little bit about research now. So, you know, there's a lot of great research in this area, and of course, you as well conducting research. So I want to know, what are some future directions with this population, with this diagnosis, that you believe are starting to kind of take hold, and we'll start seeing some really groundbreaking outcomes in the next few years?
So, you know, I've become very enthusiastic about the development of new imaging markers. By what I mean by that is, for example, you know, when I started studying this disease, Alzheimer's disease was only able to be diagnosed by autopsy, right? So the confirmation of a diagnosis of Alzheimer's disease could only really be rendered at autopsy, where the neuropathologist would see, you know, those characteristic hallmark amyloid plaques and neurofibrillary tangles in these important regions that are prone to getting the disease. Well, that's not true anymore. Now we can diagnose Alzheimer's disease in vivo because we have the means and the radio tracers and the imaging to be able to scan a person in a PET, in a CT scanner, and do what's called PET CT, and see how the brain, how these specific tracers are binding to beta amyloid protein in the brain. And so now we were able to do that with tau, and we have blood-based biomarkers that are emerging that can tell us a lot in the blood and in the cerebrospinal fluid about, elevated proteins, etc. So I'm very enthusiastic about what science has done to improve our in vivo diagnostic capabilities. At our work specifically at the Center for Cognitive Neuroscience and Aging, we develop what we call cognitive stress tests, which are related to these Alzheimer's disease biomarkers in the brain and in the blood. And so we are able to also see what are the earliest cognitive changes that occur in the brains of older adults who are at risk for the disease, but who have not yet developed symptoms of the disease. And this is critically important because, you want to catch someone before symptoms arise. And these are the kinds of individuals that we would want to put into Alzheimer's disease prevention trials, for example, right? So the people that are at greater risk, not just, all older adults, and obviously PET scans and these kinds of things, they're not very accessible, they're very expensive, but cognitive tests, they can be administered in research settings, in clinical settings, and they're, they're not invasive, they're less expensive, they're widely accessible, and so long as they are validated tests that do what they say that they do and do so reliably and are related to the biomarkers of Alzheimer's disease pathology, that's very powerful because it facilitates an earlier diagnosis. And if you can facilitate an earlier diagnosis, then that person has a greater chance of entering a treatment trial that might be the difference in their life.
And I think you said something that's key here to our listeners too. It's if it has shown to be associated with Alzheimer's, right, and validated with, so that you're not just using any type of measure that maybe you can assess for mild cognitive impairment, but if it hasn't been associated with that population, then it's not going to tell you what you need to know.
Well, because there's so many, like I said, there's so many disease processes going on when a person is aging, that mild cognitive impairment, which is at prodrome stage, there is no etiology to mild cognitive impairment. A person can have mild cognitive impairment because they have a vitamin deficiency. They can have mild cognitive impairment because they drank too much alcohol. They can have right? So there's so many things that can contribute to mild cognitive impairment that aren't necessarily Alzheimer's disease related. And when you're a drug developer and you're targeting Alzheimer's disease pathology in the brain and stopping that pathology, right, and protecting that brain, then you want to have people that have that disease process in your trial. not just a free-for-all of all kinds of disease processes, because then your drug is gonna, you're gonna have too much noise, right? You're gonna be able to meet the target, and that's why it's critically important as we develop novel drugs that we have the right people with the right pathology in these trials. Otherwise, we're gonna miss the target.
Yeah, and then you mentioned too that sometimes it's really hard, and it's important to have access and have like being inclusive, right? Have Hispanics, individuals from different cultures and backgrounds to be assessed, so that you know more about those people, and we can provide better help to them too.
Absolutely, and we have our operation at the University of Miami. We were also just awarded the One Florida Alzheimer's Disease Research Center. So the University of Miami is going to play a very big part. It's going to be what's called a clinical core site for the One Florida ADRC, and this is a Florida-wide consortium of different investigators that are experts in Alzheimer's disease and related disorders from the University of Florida, who's the primary awardee of the grant, from the National Institute of Aging, the University of Miami, Mount Sinai Medical Center, FIU, FAU. There's many institutions in Florida, great scientists that are coming together to study this illness, to study it, the way that it presents and the way that it progresses in African Americans, in Hispanics, in different individuals of varying cultures, to make sure that what we're doing is applicable, and also to learn more about how each one of those cultures, right? How, kind of very standard American culture, and how each one of these cultures plays a role in really hindering brain health or helping brain health, right? So we're very excited. And we really feel that, we're in the right place in Miami to get this job done.
Yeah, that's great to know for sure.
So, Doctor, I want to talk a little bit about healthy aging coming up, but before we touch on that, I want to ask you, going back to diagnoses, what are some common rule-outs or differential diagnoses that you'll see for this population? As you mentioned, it is a very complex presentation, right? It's not going to be straightforward, so you may have to see a patient multiple times until you're able to really confirm this diagnosis. So what are some other diagnoses that future clinicians can look out for, be aware of?
Absolutely. So when a person comes in, and they want to seek an evaluation, and their question is, is what I'm going through normal? Is it a part of aging? Is it because of, I have mild cognitive impairment, Alzheimer's disease, Parkinson's, what's going on? You're right. Sometimes it requires multiple days of different evaluations. For example, should be a very thorough clinical evaluation, where the memory disorders specialist, ideally this would happen in a specialty memory disorders clinic, but we understand that access to memory disorders specialty care is not always available. So one of the things that we love to do is help to train other individuals that are geriatric psychiatrists, neurologists, primary care physicians, geriatricians, etc., in memory disorder specialty care, right? And how to really do this right, because the older adult population is growing, it's growing rapidly, and we have to ensure accessibility and proper training to people that are going to conduct these evaluations. So they conduct a very thorough clinical evaluation, because you got to see whether there's anything else happening in the context of this person's life that can account for some of these challenges, right? So, what other kinds of medical conditions can be contributing to deteriorating cognition or deteriorating brain health, right? There could be other reversible causes of dementia, so vitamin deficiencies that can contribute to this. For substance use, a lot of the time another differential diagnosis is, cognitive disorder or dementia due to vascular illness, right? That it presents itself a little differently. The deficits are usually a bit different on cognitive testing, and has more of a stepwise progression versus that insidious continuous progression. So, a lot of the times, and we really can't neglect this, and I won't because I'm a clinical psychologist, right? Is mental health, right? Stress and mental health. A lot of individuals experience an extraordinary amount of stress, especially, you know, immigration from a new country, for example. If that immigration is more of an exiling from a new country and is intertwined with a lot of stress, and then the adaptation to the new culture, to the language, financial difficulties, these kinds of things can lead to, you know, cognitive compromise, even if it's temporary, right? Depression can be very debilitating, and a lot of the time symptoms of depression include, you know, not feeling that not feeling that you can concentrate, feeling that you're making errors, not remembering things. So a lot of the time the differential also has to be in the context of a psychiatric condition.
It's very important to be thorough, and then I think, you know, as we're still early in the early stages of this field, but I think a lot of people out there still have misinformation when it comes to Alzheimer's. So I'm glad that we have this chance to talk with you today and share this information with our listeners too, and viewers, because someone might be actually watching our video on Instagram too. And so we're talking about risk factors and rule outs too. What would be some protective factors?
So that's a great question. There are lots of things you can do to maintain your brain health. There's protective factors. For example, anything that's good for your heart, I say this all the time, anything that's good for your heart is good for your brain, right? So heart health allows, you know, the blood flow, allows oxygen to move into your brain, into your other organs. That facilitates brain health. Exercise facilitates brain health. There's been some evidence that some diets can really improve brain health. The Mediterranean diet has had a lot of research. The ketogenic diet is now of great interest. Proper sleep, right? Good sleep hygiene, enough sleep also contributes as a protective factor to brain health. Managing your stress and mood, right? So engaging in things that bring you gratification, pleasure, you know, that enhance your mood, that lift your mood, that is protective for your brain health. There's, you know, all these different things that you can do to love your brain, and those are just some, but that are power, have some powerful evidence behind them.
So for adults, let's say, you know, if you think about your mother, you know, somebody else in your family and whatnot, would you recommend, or is it recommended for people to, I guess, play games, you know, on a computer, or video games, or memory cards, or like do the puzzles, word findings and whatnot? Would those also be considered protective factors, I guess?
Absolutely, Lizzie. The thing about, you know, that, you know, cognitive exercise, cognitive stimulation, there is evidence that can really help to maintain brain health, prolong the, you know, the initiation of symptoms. The one thing that people have to keep in mind, though, when it comes to, you know, these puzzles and cognitive exercises, it has to be challenging. It has to really challenge your neurons, right? You know, learn a new language, learn how to play an instrument, do things that are going to be challenging, so that you are maximizing the output. If you're doing the same New York Times, you know, crossword puzzle that you've done for 30 years on Sunday morning, it may not be that challenging for you, right? So challenge yourself, challenge your mind. And you know, you can feel it when you're really cognitively challenged. You can feel that. Certainly there are some brain training software that have some evidence that it can help as well. So you can look into those kinds of things. And that's usually web-based and available to people for a very small amount, sometimes even free.
Thank you.
Yeah, and talking about brain health, it leads right into the conversation of just aging, right? And healthy aging. I think it's a conversation that we are having more so, and it's important to talk about the aging process and what to expect, right? And so I just want to ask you, Doctor, you know, obviously Alzheimer's is one of the more severe presentations or cognitive presentations of decline. But what would somebody expect in terms of the normal aging process to where they would maybe see some of these cognitive alterations?
Well, that's a very important question. I think, as people age, we're all vulnerable to having moments, senior moments, I've heard them called, or blips here and there in terms of perhaps, not recalling a person's name that's unfamiliar.
Right.
And you've met them before, but they're not very familiar, and you might have trouble drawing that up, or, not necessarily having remembered all the details of a certain event in your life, etc. But it's okay, that happens. Sometimes a person's ability to multitask slows down. Sometimes, there's definitely cognitive changes when it comes to usually, being a little more forgetful. That can happen. But it's important for those changes to not necessarily be consistent, right? That it happens from time to time. But it's not consistent, and it doesn't impact your life. Physical changes happen too with aging, right? So a person might physically slow down because of an injury, or arthritis, etc., right? And so these kinds of physical changes, sometimes, a person might become more isolated or less engaged than they were in the past, and that's dangerous, right? To be more socially withdrawn or to be isolated, that's dangerous. It puts a person more at risk for developing, issues with depression and also with neurodegenerative brain. It's been associated with memory decline. Right? So but with aging comes a lot of wonderful things, right? So for example, did you know that a person, well into their 70s continues to acquire language, utilize language, reading comprehension, verbal expression, these kinds of things continue to develop. And that's a plus. And then, of course, you can integrate all that wisdom you've gained and, have lots of generativity and give it back. That's one of the great blessings of aging, right? And so there's a lot of cognitive preservation that happens with aging. I always tell the story of these two research participants who we called them up and see if they were interested and reached out to us, and we said they lived far away, I think in Naples or something, in Naples, Florida. And they said, sure, doc, I'll participate in your study as long as you tell me where the best happy hour is on the Miami River, right? I was like, oh, okay. Guess how old they were.
In their 70s,
90 and 92 years old. Absolutely. So, they had found love in their 80s, found each other again after both being widowed, living full, thriving lives, traveling, participating in science, going to happy hour, doing really well. This is a beautiful model of healthy aging. This is a model that we want for our older adults to achieve. Our population is aging, and we really need to support that aging. We really need to support that independence first for their well-being, for their families, for this great, generation. And second, also for our society's health and well-being. We with older adults comprising, there's going to be more older adults in our country than children by the year 2030. That's a remarkable statistic. We've never seen that before in human history, and we need to prepare for that.
Yeah, definitely. And thank you for sharing those stories, by the way. And I think it goes, with one is reframing, like restructuring the way we see aging, right? And the word of older adults, and being 60 years old or 70 years old. Because in the past, there was a strong association. One, yes, people died younger. And then so you think of like, no, I'm 60, I'm closer to dying. And I'm retired, I don't have purpose in my life. you know, so there's a lot of negative connotation associated with aging, and there is ageism, right? So there's a lot of stigma. People suffer discrimination because of the age, your age. And so if we can navigate and shift that conversation to something more positive, or have more role models, and show that like it's okay, you know, you can still have a good life, you know.
Absolutely. You know, and that's a very, you know, that's a very subjective kind of experience, right? And I think one of the wonderful things that we can do as aging experts throughout our vehicles is try to change the culture of aging in our country, where we can embrace, you know, certain aspects of aging. Because you're right, you know, so much of it has been, unfortunately, you know, there's been negative stigmas associated with aging, and anti-aging and all these kinds of things have really overpowered of this as like something like aging is a bad thing. But you know what? Particularly now during this pandemic, what people realize that there's, you know, getting to your older adult years is really just such a victory, right? And there's so many wonderful things that can come with that, if we develop that and we choose to embrace that. So I absolutely always try and share all the pros of aging. By the way, you know, the notion of aging has really changed. I showed this great slide where it says, you know, who represents some of the older adults in our country. Well, we have wonderful, funny, really intrepid people like Betty White. You know, the Rolling Stones are now geriatric, and these are, you know, the Rolling Stones, right? And so the you know, I really do believe that, you know, 70s are the new 55, right? And some people have really embraced this, and it's going well, but we got to keep working on that.
Exactly. I remember a video somebody shared with me, and like, oh, I hope my dad won't do that. You know, I think the video is showing like a dad in white hair, whatever, like dancing, partying. You know, there's a bunch of like younger people, adults, just looking around. I'm like, hey, if my dad wants to do that, like, good for him. You know, I'm like, I just want him to have fun.
Have fun.
You know?
No judgment, just have fun.
Life is to be celebrated.
Exactly. So one more question before we finish today here. So you have done amazing work in research and clinical as well. So what would you tell students, you know, how can they, I guess, trace that path? You know, there's a lot of, again, stigma when it comes to clinical psychology and research. Like, I'm not going to do research ever. You know, how can we benefit from research, can be research consumers, and also, I guess, active participants in that field too?
Well, you know, that's a great question. You know, I think that sometimes because of our training, you know, we train so heavily as clinicians to see patients, diagnose patients, evaluate patients, take care of patients, and what a privilege, right, to be right in the front line and be able to do this very meaningful work. But we can be better clinicians if we contribute to expanding understanding and knowledge about the conditions that we treat. And here's where research comes in, right? So historically, you know, there's these different models and training programs: scientist, practitioner, the practitioner, scholar, and these models are great and fine and applicable. But you always, you know, if you're a clinically trained psychologist, neuropsychologist, physician, you know, psychiatrist, whatever, you are, number one, among the most highly studied people in the world, and you have to continue to learn, and you have to continue to study, and to continue to research, at least be a consumer of that research, right? And I'll tell you that while I love clinical work, and I identify myself as a clinical researcher, as a clinician scientist, really being able to push the boundaries of what we know about a condition and gain more and develop more knowledge and gain more knowledge is absolutely rewarding. It is a different skill set, and you have to work hard to gain that skill set. If the But if you're interested and if you see yourself as a lifelong learner, it really just folds really well, with your clinical work. And so, some of the best research has come from clinical observations that led to a question, that led to a hypothesis, that led to an entire line of research. And so, I'll tell you, students, put your heart and soul into it. Learn as much as you can, consume as much research as you can, learn how to discern, how to think critically. And if you are a trained clinician and are interested in research, connect with someone that you're interested in what they're researching. Get a skill set, get the knowledge, and contribute. We really need it, especially in the field of Alzheimer's disease, in the field of aging, of cognitive disorders. We need people that are very passionate about this. So don't reach out to people who are doing the work.
Thank you for that, and thank you for your time and sharing all your experience and knowledge with us today. We're so grateful. This has been great.
Oh, it's my pleasure. My pleasure. Thank you so much for the opportunity.
Ronnie, if you want to add a few words before we wrap up.
Yeah, Doctor, thank you so much for your time. I think this episode really embodies what our podcast is trying to achieve, and that's just to have a vessel to provide information and provide education on different processes, and specifically today, Alzheimer's and aging. And what a better person than you, Doctor. So thank you for your time, and we really appreciate it, and I hope our listeners appreciate it as well.
Yeah.
All right. Thank you. Thanks again.
Good. So I hope you all enjoyed today's episode, and you can stay Psyconnect with us on Instagram, Facebook, and Twitter. Let's Psyconnect, all one word, lowercase. And if you want to reach out to us, go to discussion@letspsyconnect.com. And remember, let's Psyconnect.